Well, first of all, thank you so much for inviting me to this conference. And essentially, I'm going to talk about what is next in the management of intracerebral hemorrhage. So I want to talk about three aspects of where we're going. I want to talk a little bit about pathophysiology, then subsequently about treatment, and then subsequently translate into what effective treatment could look like. So as we talk about the pathophysiologic processes, particularly the ones that actually have implications for treatment, I think over the last few years what we have learned that intracerebral hemorrhage is not actually a monophasic disease, but in fact it's actually a progressive disease. And essentially what we see is a progressive increase in hematoma in the first few hours, and then progressive increase in cerebral edema and mass effect as we move from a 24-hour period all the way to a 1-week period. But I think one thing I want to point out is that we've always thought of intracerebral hemorrhage as a focal disease, and now there is data coming in that intracerebral hemorrhage does not just involve a focal area of the brain, but actually may have global effects on the brain itself. And some of the research that I want to share is an assessment of global cerebral edema. So not focal edema around the hematoma or perihematoma edema, but actually an increase in cerebral volume on a global basis. And this was actually a post-hoc analysis of the ATAC study. And essentially 41 patients had serial scans, so not just a baseline and 24-hour scan, but actually a follow-up scan at 48 hours. And if you look at the volume of the brain, independent of the volume of the perihematoma edema, you can actually see that there is an increase or there is global cerebral edema in 44% of the patients that were actually studied, and the magnitude of global cerebral edema can actually be all the way to 0.12 cc to 299 cc. So I think that as we move forward, our understanding of intracerebral hemorrhage has to expand from it being just a focal disease to perhaps a more global disease for the brain. Now, how do we take the pathophysiology of intracerebral hemorrhage, which we do know actually has a primary effect, but also has activation of several secondary mediators. But nonetheless, we have to take this pathophysiology and translate it into treatment. So as we move into treatment and what is new in treatment, if you again look at the pathophysiology, appears that the main process in the first few hours is hematoma expansion, and then subsequently its mass effect. So essentially there's two main treatment paradigms. One is to prevent hematoma expansion, and then secondly to prevent mass effect. So what we do have for hematoma expansion or prevention of hematoma expansion is actually blood pressure reduction, and Professor Anderson will be talking about it next, so I'm not going to go into this particular topic, but I'm actually going to focus more on what we can do to treat mass effect and the subsequent detrimental effects of mass effect on the surrounding cerebral tissue. And what we do have today is surgical evacuation, a treatment paradigm that has been evaluated for the last 60 years, intraventricular drainage and thrombolysis for intraventricular hemorrhage, and of course hyperosmotic treatment. Now, surgical evacuation in theory makes a lot of sense. As you can see in this particular patient, you have a pre-treatment scans and then you have post-treatment scans. And you can see on the pre-treatment scans that immediately after surgical evacuation, there is decrease in mass effect. There's also decrease in cerebral edema. If you actually look at cerebral metabolism and looked at lactate accumulation by MR spectroscopy, you can actually see that there is an improvement in the lactate concentration around the hematoma after surgical evacuation. And if you look at perfusion, you can also see that there is improvement in perfusion after surgical evacuation. So in theory, surgical evacuation, in addition to reducing mass effect, may actually have metabolic and regional cerebral blood flow benefits in the tissue around the hematoma. But if you look at clinical trials, the international surgical trial in intracerebral hemorrhage being the first one, and essentially in this trial, patients with supratentorial intracerebral hemorrhages randomized within 72 hours, if you look at the favorable outcome at 6 months in the group that actually was randomized to surgical evacuation as compared to the group that was randomized to conservative management, there is no difference in the outcomes. It's 26% versus 24%. Now if you actually go further and say, well, let's look at the value of surgical evacuation in perhaps the group of patients with intracerebral hemorrhage that are most likely to benefit. So essentially looking at patients who have superficial lobar hemorrhages which are easy to access with surgical or very easy to access during surgical evacuation. And actually look at patients even earlier in time of symptom onset. So really treating patients within 48 hours of symptom onset and really initiating the treatment within 12 hours of randomization. And again, if you look at surgical evacuation, you actually look at the rate of favorable outcome at 6 months is 41% versus 38% in surgical evacuation versus conservative management. Again, a non-significant difference. So then it brings the question that surgical evacuation in theory makes so much sense, but what we don't see is a clinical benefit when it comes down to actually evaluating it in a randomized clinical trial. And some of the explanations could be that there's perhaps neural injury when you're retracting and dissecting the tissue to actually get to the clot itself. Again, we may have difficulty in complete removal of the clot, so there may be residual clot that may be left even after surgical evacuation. Again, the risk of rebleeding, so as you remove the hemorrhage or the hematoma, you may also lose the local tamponade effect and there may be rebleeding in the operative field. And that actually shifted the thought to minimally invasive strategies. So rather than the classic surgical evacuation, but actually look at minimally invasive strategies to evacuate the hematoma. And that actually brought us to the minimally invasive surgery. And essentially one randomized trial, probably the largest one that has been done and recently reported, is the minimally invasive surgery plus Alteplase in intracerebral hemorrhage evacuation, or the MISTIE trial. And in this particular trial, patients who came in with an intracerebral hemorrhage, the hematoma volume being 20 ml or greater, so 96 of these patients were randomized, either to actually minimally invasive aspiration, so not the classic surgical evacuation with a classic craniectomy or craniotomy, but actually just a small burr hole, and essentially placing a catheter within the bed of the hematoma and aspirating the hematoma, and then subsequently infusing thrombolytics, Alteplase in this particular trial, on a serial basis to make sure the thrombus is actually dissolved and further evacuated to ensure, one, complete evacuation, and also approaching the hematoma in a minimally invasive way, so to limit the damage that can be done during open craniectomy or craniotomy. And essentially the TPA was given like 0.3 milligram up to 1 milligram every 8 hours, and a total of 9 doses could be given into the hematoma bed. Now if you look at survival at 1 month, it was 91.5% versus 85.2%. Obviously this is a pilot trial, so it's not powered to show statistically significant difference, but nonetheless there appears to be some benefit in mortality at 1 month. Now the other thing that has been in investigation is intraventricular hemorrhage, which is something that occurs with intracerebral hemorrhage, particularly large intracerebral hemorrhages. And even in the days when CT scans were not available, pathological studies also showed that patients who actually had intraventricular hemorrhage clearly had a much greater magnitude of cerebral damage and also much worse outcomes. And part of it may be because you may get obstructive hydrocephalus because of the blood actually being accumulated within the ventricles. There's also periventricular edema and also global cerebral edema that has been defined in patients who actually have intraventricular hemorrhage. And of course, inflammation in the ventricles itself. So in theory, it makes sense that you can actually put a ventriculostomy and remove the hematoma that's accumulated in the ventricles. However, because this blood is actually clotted, with just placing a ventriculostomy and allowing spontaneous flow through the ventriculostomy, the effect may be limited. So that actually has brought us into the era of actually instilling thrombolytics. And now know that the concept seems a little contradictory, that we are actually giving thrombolytics in patients with intracerebral hemorrhage. But nonetheless, it is a strategy where you actually instill thrombolytics through the ventriculostomy into the bed of the hemorrhage that's in the ventricle itself to dissolve and subsequently remove it. So the Clot Lysis, evacuation of accelerated resolution of intraventricular hemorrhage, or the CREATE trial, was a phase 3 trial, and it actually looked at patients who had intracerebral hemorrhage with obviously intraventricular hemorrhage. And the intracerebral hemorrhage had to be small, and the intraventricular hemorrhage had to be large enough that actually blocks either the third or fourth ventricle. And the patients were randomized either to just receive intraventricular saline. So essentially both groups actually had a ventriculostomy placed into the ventricle. So one group actually got serial doses of intraventricular saline, and the other group got intraventricular TPA, and that was 1 milligram every 8 hours, and a maximum of 12 doses could be given. And the goal again being to dissolve the thrombus so that it can be removed through the ventriculostomy from the ventricular cavity. Now if you look at favorable outcome at 6 months, unfortunately the rate did not differ significantly. It was 48% in the group that got intraventricular thrombolysis with cerebrospinal fluid drainage versus 45% in the group that got saline plus cerebrospinal fluid drainage. But there was actually a mortality benefit. So if you look at survival at 6 months, essentially it was 82% compared to 71%, a highly significant difference. But unfortunately what it looks like is that yes, survival is improved, but the outcome of people who are surviving, they're really not favorable outcomes. In fact, we are just taking survival and turning it into severe disability. So what we have learned is that perhaps even with minimally invasive approaches, the magnitude of benefit is not as much as would have been predicted on a theoretical basis. But perhaps because secondary injury to the brain has already been initiated, so removing the focal stimulus does not really change much into the cascade that's already ongoing. We also have learned that we need to be cautious, that in these strategies we are not just reducing death at the cost of increasing severe disability. So essentially if there is a survival benefit, it should be a meaningful survival. But actually the positive message here is that if you look at the outcomes in these trials, for example, if you look at survival at 6 months in patients with intraventricular hemorrhage, even in the group that got so-called saline treatment, 71% of these patients were actually alive at 6 months, which is a much higher survival than we have seen previously based on the natural history studies of intracerebral hemorrhage. And I think there is some value in the overall outcomes, improved outcome in recent trials because of standardization of the multifaceted care parameters. And I think we must also understand that perhaps not one single strategy will make a big difference in the outcome of patients with intracerebral hemorrhages. And perhaps there is more emphasis on the multifactorial determination of outcome in these patients. And the last thing I want to quickly talk about is effective treatment. And if you look at studies with patients with intracerebral hemorrhages, there's at least 18 facets of care, 18 phases of medical care that have been shown in the literature to improve the outcome of patients with intracerebral hemorrhages. And you can actually derive 26 quality indicators based on those 18 facets of care. And you can turn it into an algorithm. So essentially there is a semi-quantitative way for you to assess how effective you are in terms of the intensity of medical care that you're providing for the patient with intracerebral hemorrhages. And I think it just comes down to the multiple quality care indicators and the big picture integration. there's not going to be a one single intervention. There's going to be a multitude of interventions that will be required to improve the outcome of patient with intracerebral hemorrhages. And you can semi-qualitatively grade them, that how effective you are in providing that intervention, and even give it a score. So a score of 1 if you provided the intervention in timely and effective manner, and a score of 0 if you did not or you failed to provide that particular intervention for that particular quality parameter. So essentially, if you come up with this intracerebral hemorrhage specific intensity of care quality matrix, you can actually have a low performance, which will give you a score of 17, which means that you really did not do well in any of the quality parameters. And on the other hand, if you performed very well in providing all the 26 quality parameters, you would actually get a score of 26. So we actually looked at patients with intracerebral hemorrhage, 50 consecutive patients, and we graded them. So the lowest score was 17 and the highest score was 26 in these patients. So in theory, you actually have a score in terms of how effective you are in providing intensity of care based on the intensity of care quality matrix. But does it really portray or predict outcome of the patients? So if you look at survival in these patients, so in patients where the score was low in the intracerebral hemorrhage specific intensity of care quality matrix, the survival was low, and where the score on the performance matrix was high, the survival was high. So there is almost a linear relationship between how effective you are in terms of providing a intensity, or how effective your intensity of care is in terms of medical management of intracerebral hemorrhage and the subsequent survival of patient with intracerebral hemorrhage. So I'm actually going to conclude with the following statements. I think that intracerebral hemorrhage is no longer an untreatable form of stroke. I think aggressive but multifaceted management can improve the outcome of patient with intracerebral hemorrhage. And I think we must continue to support future clinical trials to ensure that the treatment of intracerebral hemorrhage is evidence-based and impacts favorably upon patient care. Well, thank you very much.